Hello, my name is Rosemary Bartholomew. I'm an evaluator with the Department of Health and Human Services, Office of Inspector General. Our mission is to protect the integrity of HHS programs, as well as the health and welfare of their beneficiaries. Today I'll be discussing what OIG learned in two recent studies examining hospitals' preparedness and response to infectious disease. The first was conducted after the 2014 Ebola outbreak, and the second was conducted in March 2020 during the first surge of COVID-19. Back in 2014, the domestic outbreak of Ebola tested U.S. hospitals' ability to respond to an emerging infectious disease. Although very few U.S. hospitals ended up receiving suspected or diagnosed cases of Ebola, the disease's presence caused hospitals to assess and improve their preparedness for future infectious disease threats. In 2017, several years after the Ebola outbreak, OIG surveyed a national sample of hospitals to ask about how prepared they had been for Ebola back in 2014, and to ask whether they were now prepared for the next infectious disease. We confirmed what many suspected, that most hospitals in the U.S. were not prepared for Ebola at the time. However, after the Ebola threat, hospitals took a variety of actions to improve their preparedness, including revising their emergency plans, increasing staff training, conducting drills and exercises, and purchasing additional resources. Hearing about the types of improvements that hospitals made and the pros and cons of some of the approaches may assist you in improving your own preparedness. Most hospitals reported that they had revised their emergency plans to improve preparedness for emerging infectious diseases. Much of the improvement in emergency plans was focused on building in redundancies for needed staffing and supplies. For example, hospitals sometimes use their plans to map out which staff they would need during each particular kind of emergency and where they would turn for supplemental staff, for example, from another hospital within their network. In addition to revising their emergency plans, nearly all hospitals reported that they conducted staff training in emergency procedures and clinical procedures to handle patients with emerging infectious diseases. One approach that some hospitals took was to focus their training on forming rapid response teams that could be deployed as needed. These teams included clinicians and staff members across disciplines, such as emergency management, infection control, nurse leadership, and laboratory operations. A number of administrators noted the value of providing training across the hospital, including to both clinical and non-clinical hospital staff. For example, physicians, administrators, frontline reception staff, and environmental service workers. One hospital administrator stated that having departments trained together created more open communication, which served to better identify and address the needs of each department. As part of staff training, most hospitals conducted full-scale drills and/or tabletop exercises that included a scenario related to an emerging infectious disease. Hospitals noted that full-scale drills are more labor and cost-intensive than tabletop exercises, but several explained that they were strong proponents of this practice because full-scale drills were more insightful than tabletop exercises in identifying gaps in preparedness, particularly gaps related to facility infrastructure and patient care handoffs. But some noted that one benefit of tabletop exercises was that hospitals could plan and conduct them more easily. Many hospitals conducted both drills and tabletop exercises. Another way that hospitals improved their preparedness following Ebola was by purchasing additional resources such as equipment and supplies. Common types of purchased supplies included protective equipment, medical waste equipment, and clinical equipment that hospitals planned to dedicate exclusively to infectious disease patients. Many hospitals noted that in 2014 through 2015, they'd encountered difficulty in acquiring these supplies as a result both of manufacturer shortages and the limited number of providers of certain services. However, a few administrators referenced past lessons learned that had made them cautious of overbuying, such as one hospital that had stockpiled respirators during the 2009 H1N1 flu pandemic, only to have to discard them later because they had expired before they could be used. Although there were lessons learned and improvements made following the Ebola outbreak, the COVID-19 pandemic brought a new set of challenges for hospitals. In a report issued in April 2020, we described some of the challenges hospitals faced during the early days of COVID-19 and the strategies that hospitals used to respond to those challenges. We collected this information to assist HHS, Congress, and other decision makers as they work to respond to the COVID-19 pandemic. and to share information about strategies that hospitals were using in case they could be helpful to others. Learning about some of the strategies they employed for 3 key challenges may help you develop your emergency plan. The first key challenge hospitals reported during COVID-19, and that can come up in any emergency, was equipment shortages and supply chain disruptions to secure additional equipment and supplies. Hospitals had 2 general approaches to address this. Either try to get equipment and supplies from new or non-traditional sources, and/or work to make existing equipment and supplies last longer. For example, many hospitals face shortages of personal protective equipment, or PPE, such as masks and gowns. To try to secure additional PPE, some hospitals looked for online retailers or other potential sources they hadn't used before. A few hospitals turned to other industries that use protective masks, like auto body shops, paint stores, and beauty salons. In your emergency plan, it may be a good idea to identify potential alternative sources of key equipment and supplies. To preserve their existing supplies of PPE, hospitals reported implementing new procedures for conserving the equipment. Often this meant educating staff on how to preserve PPE and securing scarce supplies to prevent theft or misuse. New policies included using different levels of PPE depending on the patient's condition, or reducing the extent and frequency of patient interaction in order to reduce PPE burn. For example, by doing as much for a patient as possible in one interaction, rather than going in and out of the room and changing masks and gowns every time. Identifying a conservation plan in advance might help to reduce confusion in an emergency and help to preserve key equipment and supplies. The second key challenge hospitals faced during COVID-19 was ensuring adequate staffing to care for patients, which included the need to combat employee burnout. To help address this, some hospitals cross-trained medical staff to help meet new needs. For example, training anesthesiologists and hospitalists to help care for patients on ventilators. Other hospitals noted that having a partnership with a large health system was beneficial because they can deploy medical staff like nurses to other hospitals in the healthcare system that may be experiencing a staff shortage. To help address burnout, some facilities reported assisting staff to access services such as childcare, laundry pickup and drop-off, and grocery services. Some also reported offering or expanding resources for emotional and psychological support. For example, one hospital shared it had recruited external mental health clinicians and engaged its own psychiatry staff to help alleviate anxiety among hospital staff. In your emergency plan, you may want to consider what avenues might be available to you to ensure adequate staffing and how you could work to support staff needs in an emergency. The third key challenge that hospitals faced was managing patient flow and hospital capacity. To address this, hospitals worked on 2 fronts. First, to keep people out of the hospital that didn't need to be there, and second, to expand capacity for those that did need to be hospitalized. One way that hospitals kept people at home was by using telehealth services when possible, which helps protect both patients and staff through social distancing. Other hospitals described efforts to educate community members about COVID-19 testing processes to avoid having patients come to the hospital unnecessarily. To guard against bed and facility shortages, some hospitals converted or created new spaces to house patients. This included expanding their intensive care units, repurposing existing spaces, and sometimes using temporary spaces like tents. Some hospitals also described plans to make use of other facilities, such as local fairgrounds, vacant college dorms, and closed correctional facilities as additional space for patient care in the event of a surge. Considering potential spaces that could be repurposed in the event of an emergency might be helpful as you develop your emergency plan. I hope that hearing about some of the ways that hospitals tried to prepare for and respond to infectious disease has given you some ideas for areas to address in your emergency plan. For more information on emergency preparedness, watch OIG's companion videos listed on this slide. Thanks for watching.